So let's move to axial length as a progression indicator in pre-myopes, emerging myopes. Jonathan, what do you have to say about our next point?
So axial length is creating almost a paradigm shift in the way that we view myopia. Whether we're treating a pre-myope, an emerging myope, or an existing myope, as Cheryl was pointing out, it can dramatically alter the way that we expect maybe the rate of progression and or the risk of future pathology in the eye. Referencing the article that you did at the beginning, Matt, at the myopia profile article. If you look into what they reference in some of the scientific articles that they reference, it talks about how axial length is really a prime indicator for younger pre-myopes. It can be so useful in determining if they're going to likely become a myope, and then not only that, a high myope, versus someone who's an established myope. It's a useful piece of information. So I think it can alter the way that we kind of classify and decide to treat or not treat a low myope based on their prior axial length measurements, if they're had. So Michael, I wanted to turn it to you and talk to you a little bit about that. What are your thoughts on axial length and early or pre-myopes?
I think if we look at the early myopes, we kind of look into the future. We have our little crystal ball and we say, well, we know from a number of studies that axial length over 26 millimeters as an adult is a high risk factor. So when we look at kids and know that they are going to grow and develop, our goal should be to say we want to keep them well under that and limit axial growth. So to get back more specifically to your question, I think, the difficult part of it for us right now is you can't really look at this and have normative data. We don't have a real gospel that says this is normal axial length for emmetropes developing, and if it's more than this at a specific age, then this is an at-risk child. There are a number of studies, and I think we're trying to develop that normative data right now. So, for example, you might say, okay, if I have a 6-year-old and they're over, I don't know, what is this? One chart that I have over 22.5 millimeters, that may be an at-risk child. But there are a few studies that are trying to propose what is normal. Again, I think we have to take axial length as an important contributing factor, and as one contributing factor. We have to look at the refraction, we have to look at progression, family history, and all the factors together. So I don't know, I hope that starts a little bit of conversation, and Cheryl and Jonathan, you can kind of chime in a little bit based on that.
Yeah, I'll speak a little on that. I know I've mentioned on some other podcasts, and some people may have heard me say this before, but I've started measuring axial length on pretty much every kid that comes through clinic, whether they're hyperopic, whether they're myopic, and I found that to be extremely useful in some specific cases, because if I have data on that kid when he's 5 years old, and then he comes back again when he's 6, and then he comes back again when he's 7, I can watch for these trends. The article we're referencing tonight, it was written by Kate Gifford, right? Well, in those white papers that came out a couple of years ago, she kind of accumulated data from a lot of different studies, and it talked about how we are going to see that axial length growth is going to start to pick up and accelerate up to 3 years before they even transition into myopia. And then that 12 months prior to transition into myopia, from hyperopia to myopia, you're going to see an even greater acceleration. And so what I'm doing is I'm trying to watch for these trends. And I've got kids who they're kind of right there on the cusp. And I know there's this family history and maybe a sibling that's already in myopia management. And so a lot of times what I'm doing is seeing this at-risk 5 or 6-year-old back maybe every 3 months or maybe every 6 months, and rechecking their axial length along with their refraction to kind of see. And I've got kind of a fun case where Mom is like a -8 before she had LASIK, and older brother was, I think he was like -1 and 150 when he started myopia management at age 6. And his little brother, we saw, wasn't as hyperopic as we expected at a young age. And then as he like was coming right up to, he's like at plano right now, and I've got him on atropine therapy. And that's the exciting thing is, okay, yeah, it's almost like a crystal ball. And I've seen like his axial length was rapidly progressing right up till plano. We intervened with atropine therapy, and now I've seen him back for 2 different follow-up visits where he's now stable. I'm like, this is so cool. Like he is gonna stay hopefully around this plano, or maybe only progressing to a very, very low myopia instead of maybe becoming a -8 like his mom was. So that's pretty cool.
One other point, I guess, is that really, truly with doing orthokeratology, we really have to depend on axial length because we really can't monitor the refraction, a true refraction. We can do some modifications to try to estimate what it is and changes in parameters, but truly, if you're doing ortho-K, the best way to monitor progression is with axial length.
All right, so I asked for questions before we started this podcast, and one of the questions that I got from our audience was, what level of myopia to axial length is medically acceptable to prescriptions for traditional therapies without the need of ortho-K, atropine, etc. So I wanted to throw that into the conversation as well. Cheryl, what do you think?
Yeah, I mean, that's kind of what I'm talking about. If I understood the question correctly, that's kind of what I'm talking about, where I saw this kid and I'm like, I don't really care what your axial length is. What I've seen is that it's progressed very fast. And I see that you're only 6 years old and you're going to become so myopic if I don't do something. So why not start now? Why wait? And so we started him on atropine therapy.
Okay.
Are you guys comfortable prescribing ortho-K for an 8-year-old child who's -1?
I am, personally. I don't know about you, Jonathan.
I would be. Yeah, I mean, ultimately, I think that's going to be, kind of the crux of this whole conversation. But kind of, yeah, getting to that point, I would be for lots of reasons that we're going to hopefully discuss. But sure. How about you, Michael?
I definitely would. And again, it would kind of be evaluating the whole picture, meaning you're looking at the refraction, the age, progression, previous prescriptions that the kid has been wearing, and basically, family history and just other risk factors.
Circling back to something that Michael said a moment ago that I think is somewhat relevant. When we're looking at axial length and we're treating these orthokeratology patients, one thing that I've noticed and has been documented, I know a lot of practitioners are noticing this, is once you start a patient on myopia management, whether it's atropine, whether it's soft multifocal contacts, or whether it's orthokeratology, a lot of times when really good myopia management is happening, you will get some thickening of the choroid. And that choroidal thickening will often lead to an axial length measurement that slightly makes the eye look slightly shorter than it was previously. And I have seen a couple of cases, specifically with ortho-K, where it made me feel like these kids they were kind of progressing, and we either switched into ortho-K from a different therapy or we added dual therapy, and all of a sudden I get them back for that follow-up visit, and now I've seen their axial length, instead of getting a little bit longer each time, now it's a little bit shorter, and I'm like, bingo. I know that the eye is like recognizing that there's myopia management happening. I know I'm getting that stop signal for axial elongation, and I'm getting that choroidal thickening. So that is like so exciting for me when I see that.
That's a great point. It does happen, and we have seen that. And like you, Cheryl, we started doing axial length on every child under 18 that we saw when we started the SMART study in 2007. So at that time, we were using ultrasound to do that. But after a number of years, we moved to some optical biometry, and been still doing it on every kid under 18. So there are definite signs of actually reduction, and we know we can't shrink eyes. So
So let me interject, Michael, and say it's very possible that listening to things that you said or reading things that you wrote may have given me that idea to do axial length on all these kids. So in case it was you, thank you.
no problem.